Sankar. Good morning, students. Today we are going to have three sessions. First will be session on pandemic management module, which is introduced by the council considering the COVID pandemic which we are facing. They thought that students should have sufficient knowledge and skills which is required in case of pandemics. Then after that there will be a session by Dr. Anand Bhide on principles of primary health care. And the third session today will be taken by Dr. Anup Kharde, and that is on national health policies and programs. So I begin with the first session on pandemic management module, and after my session I will be putting this PDF which is given on the website of NMC on your Google Classroom as well as WhatsApp groups. So we begin with the today's session, pandemic management module. So I told you this is a longitudinal module which is introduced right from foundation course in first year, second year, third MBBS part 1 and third MBBS part 2. Now in foundation course, we are supposed to cover history of outbreaks, epidemics and pandemics. And 2 hours are meant for that, and our department, that is community medicine, will cover this. Coming to phase 1, there are 4 hours which will be covered by microbiology, which includes infection control practices, hand washing, decontamination and use of personal protective equipments. Then when you will go to second MBBS, second phase, so these are the contents of pandemic module. 2.1, 4 hours will be taken by microbiology on the topic infection control part 2, that is airborne precautions, contact precautions and infection control committee. Then next 6 hours will be covered by community medicine, module 2.2, emerging and re-emerging infections, early identification and control of new infections. Next, module 2.3, 6 hours will be covered by microbiology again on the topics sample collection, microbial diagnosis, serological test and their performance parameters. Then 2.4 will be covered by community medicine, biochemistry and pharmacology jointly. This is for 6 hours, 2.4, and the topic are vaccination strategies including vaccine development and implementation. All of you know that now government has started a drive to vaccinate high-risk individuals, healthcare professionals across the India, and knowledge of vaccines and vaccine development and research is very important for medical students. The next, there are 6 hours, module 2.5, covered jointly by pharmacology and medicine department, and the topics are therapeutic strategies including new drug development. Now this was about second MBBS. Third MBBS part 1, these are the topics. 3.1, 5 hours. Now all these topics will be covered by community medicine. 3.1 includes outbreak management, including quarantine, isolation and contact tracing. 3.2, interdisciplinary collaboration, principles of public health administration, health economics and international health. Module 3.3 will be on operational research, field work and surveillance. Then they have also mentioned about electives, where the topic is epidemiology and research components. All of you know competency-based medical education. There are 2 electives of 1 month each. So one of the electives can be on epidemiology and research components. Coming to 3rd MBBS part 2, that is final. Now I will read the modules. So module 4.1 is care of patients during pandemics. 6 hours are meant for that, and it will be covered by general medicine. Then emergency procedures, module 4.2. Death related management, 4.3. Communications and media management, 4.4. Intensive care management during pandemics, 4.5. And palliative care during pandemics, 4.6. And the respective hours for these modules: 4.1 we have got 6 hours, 4.2 8 hours, 4.3 2 hours, 4.4 4 hours, intensive care management 4 hours, and palliative care 4 hours. And the departments which will be conducting jointly are general medicine, pulmonary medicine, anesthesiology, FMT, and medical superintendent office. And this will be integrated session. Thus the total module prescribed by NCI and NMC is of 80 hours. And I will be putting soft copy in PDF format on your WhatsApp group as well as Google Classroom. Now in short, we will see what are the skills to be developed from undergraduates by virtue of this module. What are the expectations of the council? So skills suggested: history of outbreaks, epidemics and pandemics, covered by so this is module F1. The student should be able to define pandemic and differentiate it from outbreak or epidemic. This is first one. Now when we say epidemic, it is unusual occurrence of a disease or an event clearly in excess of expected in a given population. And when we say it is endemic, constant presence of a disease, of course at a low level in a defined population or in certain pockets. And when we say it is a pandemic, when it is affecting a large geographical area, often crossing international borders. So right now the COVID is a pandemic. Then in foundation course, module F1 has got other objectives to identify the reasons or events that led to pandemics in the past, and describe key strategies by state and central government, NGOs and society at large that were adopted in prevention and control of these pandemics. Then discuss the role which will be played by national and international bodies like WHO and ICMR if these events take place. Now, I will be restricting myself to the discussion on the competencies which are related to foundation course, that is history of outbreaks, epidemics and pandemics. So I request everyone to read the PDF and answer these questions and write as the reflections in your notebook, which again you have to write in your logbook. So thank you for your patient listening. Now I invite next speaker, Dr. Anand Bhide, who is Assistant Professor in Department of Community Medicine, and he will be speaking on principles of primary health care. So over to Dr. Anand Bhide.
Good morning, guys. Thank you for this. So the last time I had taken the virtual visit of IPD for your batch, and today we'll be talking about what primary health care is, what health is, what care is, what does primary mean, and what are the principles of primary health care. Right? If you have any doubt, you can ask me on the WhatsApp group that is available, or you can email me your doubts. Okay? This is just a briefing session. So the PPT is this topic is a whole theory topic, and it is a long answer question for your exam. But in first year, as a part of foundation course, we just want you to be briefed about what primary health care is, right? So principles of primary health care. My PPT covers the ALMA-ATA declaration, attributes, components, and principles. Okay. Health is fundamental right of every individual, right? Integrated care comprising preventive, promotive, curative, and rehabilitative services. Health care extends from womb to the tomb. Key scenario to socio-economic development and progress of the country, organized in 3 levels: primary, secondary, and tertiary. Okay, there are primary levels at primary healthcare center. There are secondary levels, which includes district community health centers and then higher hospitals, and the tertiary level care that is provided by large hospitals and district hospitals, then civil hospital, and also medical colleges. We come at tertiary level care. So we are talking about primary health care, the lowermost, and which covers the larger section of the population. Most of the care in the community is provided at primary level, which is near to the community and which is also easily accessible and affordable. Okay. See, tertiary care. So tertiary care, the development of medical instruments and sciences has we can say that it has killed more people than it has saved. Why? Because the burden of this development of technology is very costly. It takes away all the savings of most of the people. It takes away all the जमा पूंजी जो है एक आदमी की जिस जिंदगी भर वो जो पैसे जमा करता है, it takes away everything that they have earned, right? So you understand what I mean. So development in science and technology is obviously costly. I'm not saying that it is not necessary, but it is very costly. So if we try to prevent the diseases or treat them or cure them at the primary level, at the community level, which is so cheap and in terms of economy, and it is also available to everyone, then we don't have to spend so much on tertiary level of care. So this is a very milestone in the if we talk about primary health care. This is a milestone, the ALMA-ATA conference of 1978, right? It is a milestone of public health or community medicine. It had set a goal, right? What were the objectives? The objectives of this conference was to promote primary health care, to evaluate the present situation, to define the principles, to define roles of government or organizations, and to give recommendations, right? To understand what the situation is, to define what can we do, to define what will be whose role, the role of the government, role of the state, and role of private organizations, and to give recommendations to these role bodies, right? So what did they declare? There was an existing gross inequality in the health status of the people, and people also have a right and duty in participating individually and collectively. Primary health care is essential. An acceptable level of health care for all the people by 2000 had to be achieved. So this was declared in 1978, right? We are 20 years beyond the declaration of ALMA-ATA, and we all know what the situation is. So what is definition of primary health care? It is an essential care that is universally accessible, which means full participation of community, and at a price where country and community can afford, right? So these are the 4 important words. It is essential, accessible. You cannot say कि वो हॉस्पिटल है लेकिन कश्मीर के पहाड़ी पे, ऐसा नहीं है. उसकी कम्युनिटी में होना चाहिए वो हॉस्पिटल, वो सर्विस जो है. You cannot say कि there is this particular community which belongs to this particular community and they follow a certain sacred ritual and practices, and you cannot enforce a new scientific method on them. You will have to develop a scientific technique or method which is acceptable to their community and culture, right? So that is what acceptable means. Then they should also participate in this thing, and obviously it has to be affordable to the community and to the state. So what is primary health care? An essential health care made universally accessible to individuals and acceptable to them through their full participation at a cost the community and country can afford, right? What are the attributes? Attributes of primary health care are essential health care. It is universally accessible, acceptable, it should be community based, first point of contact, affordability, adaptability, appropriateness, community participation, continuity, comprehensiveness, and coordination. Now, if we take into consideration the drugs that are given, drugs and services that are provided, medication and services that are provided for treatment of tuberculosis by government. So it is essential, it is universally accessible, it is available in every part of the country, it is acceptable by the community, it is community based, we orient the drugs which are appropriate for the community, it is available at the first point of contact in the village and the remotest tribal area, it is affordable, it is free for the people are adapted to it, we have adapted our strategies to the people, it is appropriate, it treats the tuberculosis perfectly, community is participating, there are so many volunteers and non-government organizations which motivate the heroes and actors and actresses which motivate people to use the tuberculosis drugs. The drugs are available since long time and are always available at the centers. There is continuity in treatment, there is comprehensiveness, and there is well coordination. It is available in a well coordinated manner, right? So attributes continued are accessible, affordable, acceptable, appropriate, and adaptable. Then there are, these were attributes. Now we are talking about components. What are components of primary health care? First and foremost is education. Second is food supply. Third is water. Fourth is maternal and child health. Then immunization, control of endemic diseases, treatment of common diseases, and provision of essential drugs. Right? The components are education, food supply, water supply, mother and child health, immunization, control of endemic diseases, treatment of diseases, and drugs, availability of drugs. Now today's topic. So today's topic is about principles of primary health care. Now principles, this is a very important question and you have to remember this throughout your life. 4 principles: equitable distribution, community participation, intersectoral coordination, and appropriate technology. I'll try to make you understand what these 4 terminologies mean with help of examples, right? With help of examples, I'll try to make you understand. So first and foremost is equitable distribution. Obviously, inequality in the availability of health services is our major concern. Supply of healthcare resources more towards affluent areas, right? Inverse care law. Biggest hospitals and biggest metropolitan and multi-speciality hospitals are always placed in an urban area, while as the rural areas require them the most. So this inequality exists. First key principle in primary health care is equitable distribution. It ensures that individuals with more compromised health conditions must receive more health services. Commitment to health equity focuses not only on ensuring program inputs but also reducing differences in health outcomes. Right? Access to healthcare can be horizontal equity or vertical equity. Horizontal equity is equal access for equal needs. That means the resources are equal for everyone. equal access to healthcare, equal utilization of health services, and equal health. Then what is equitable distribution in vertical quantity? Unequal should be treated in proportion of their inequality, right? Like there are separate seats in bus reserved for old women or say females. So that is vertical equity. We are treating the underprivileged with more privilege, so that they stand shoulder to shoulder with everybody else. Individuals with more needs should have more treatment. The central theme of need therefore determines equity. What are the aspects? Aspects are access to health must be equal, the health must be equal, and the coverage must be equal. For example, in Tripura, an helicopter services is provided. In Andhra Pradesh, free bus service is provided to pregnant women. In Assam, Akka ship is provided to for reaching the islands. In Tamil Nadu, concept of birth resorts is introduced in remote and hilly areas. Okay, so all these principles, all these examples, they are providing the maximum services to the last person standing in the community, and that is also mission and vision of Pravara Institute of Medical Sciences. Providing services to the last person. Socioeconomic inequalities are widening than narrowing. Failure of publicly financed healthcare to reach the poor people. Too little knowledge about the relative importance of inequalities in determinants of health utilization. Too little is known about the impact of programs and policies on health sector inequalities. Lack of knowledge. What can we do to overcome this inequality? Concern of attaining high health equality is no longer the domain of health professionals only. It is not just duty of health professionals. Multidisciplinary action involving diverse resources must be taken. Adoption of Millennium Development Goal and Sustainable Development Goals. International initiative to attempt at equity. So what are the Millennium Development Goals? I'll just go through it. Eradicate extreme poverty, achieve universal primary education, gender equality, reduce child mortality, maternal health, combat STDs and HIV, ensure environment sustainability, develop a global partnership for development. Then the second principle after equitable distribution is community participation. Involvement of individuals and families and community means community participation. Determines both collective needs and priorities. Important role in formulating a health problem, make informed choices, objectives with community priorities. Universal coverage cannot be achieved without involvement of local people. Like supposedly if you introduce a new theme or new drug into the supposedly a new birth control method into a community, you cannot go as a doctor and speak to the people directly. They will not listen to you, they may not be interested. If at all they might get angry, right? They might get furious at the scientific language or whatever the thing is. So what do? We try to influence the people, political leaders, social leaders, old people, like school teachers in that community, and try to get them involved into this program, right? So what will happen when these people whom the community trusts, they get involved and they gain trust over us, obviously the trust is passed on and the success rate of program increases. So I'll give you an example of barefoot doctors. So China, like India, had very high problem of communicable diseases in 1965. So what did they do? They trained the rural farm workers. They were given basic knowledge of health training to provide combination of traditional as well as Western medicine. Right? The farmers barefoot, bina chappal wale doctor. So they were trained in basic medicine, their own Chinese medicine and Western medicine, the combination. And what did happen? The results were outstanding. They had mostly wiped out the communicable diseases, right? Then there are two types of community participation. One is active, cooperation plus resources. Then there is passive. We don't give them resources, we just ask them for cooperation. What is advantages? Increases program acceptance and leadership. Ensures that program meets the local needs. Cost of implementing the program may be reduced. Uses local familiar organizations, hence problem solving is efficient. Commitment to decision is facilitated, and it is a key to sustainability. What are the examples of community participation in India? VHG, Village Health Guides and Trained Guides and Asha Thais. Then they are selected by the local community and trained locally. Essential feature of healthcare in India, right? The third principle is intersectoral coordination. Primary care involves, in addition to health sector or related sectors and aspects of national and community development, includes sustainable participation that combines inter-organizational cooperative work alliances, possibly but not necessarily in collaboration with the health sector. What are the prerequisites for intersectoral coordination? Proper orientation of policies and programs, formation of joint coordination committees, defining roles and responsibilities of agencies involved, participatory decision making, developing formal system of interaction, discussion and debate, sharing of problems faced in implementation, spelling out strategies and procedures, joint evaluation and monitoring. Mechanism of coordination is listing out names of different sectors, identifying the NGOs and VOs, constitute the district level and coordination committee, formulate specific task force, jointly decide the objectives and areas, decide the role and responsibility, development of a plan. You'll learn this planning cycle in detail later on. What are the difficulties faced during intersectoral coordination? It creates conflict of interest between different fields that are involved. Power struggles. Agencies must be able to compromise and impose change on normal working patterns. Cultural changes. Coordination may turn out to be more expensive in terms of manpower and money. Irrespective of disadvantages, intersectoral coordination is the key principle outlined by World Health Organization in Health for All that has to be achieved. An outstanding example of intersectoral coordination at grassroots level is Anganwadi as part of Integrated Child Development System and Program. Examples: Ayush, convergence of Indian system of medicine with modern medicine, coordination with rural health practitioners. In Bihar, Janani or Titli and Surya clinics, coordination with non-government and civil organizations. Partners, I'll give you an example. Government of Karnataka and Apollo Hospitals, Hyderabad, Raichur handed Apollo Hospital under management contract. Services is 350 bedded hospitals, free to below poverty line patients. Partners are Government of Karnataka and Karuna Trust. And services that are provided are OPD, emergency, ECG, X-ray, lab services, etc. So this is a good example of intersectoral coordination where government, NGO and private sector are coordinating with each other to execute and make these services available to the remote areas. The final and the fourth principle of primary healthcare is appropriate technology. Technology that is scientifically sound, adaptable to local needs and acceptable to those who apply it and to those whom it is used and is maintained by people themselves. So the technology must be scientifically sound, adaptable, acceptable, and the technology that can be maintained by the people and does not require scientific or say rocket science knowledge. It is designed to make specific health needs. Criteria for choosing which needs should be addressed include magnitude of population affected, the degree of morbidity and mortality caused by that conditions, Lack of solutions that are effective, safe, acceptable, affordable, accessible, and sustainable. An appropriate technology should be scientifically valid, adapted to local needs, acceptable to users, maintainable with local resources. Technology only effective if accompanied by knowledgeable and skilled users, clear practice guidelines and policies, effective financing and distribution to make them universally available, community efforts to bring clients into contract with health services in a timely way. Only have impact if incorporated into a comprehensive health delivery system. Defining the attributes and characteristics of appropriate health technologies needs to take place early. Examples: use of color tape for measuring mid-arm circumference, right? Use of oral rehydrating solution packets, tender coconuts for rehydration, growth chart maintenance for under 5 children. HMIS and telemedicine. So primary health care in India is provided to the population by a primary health center, right? 80% of health needs can be met by a primary health care center. A PHC is always available and at a community level. 30 years after ALMA-ATA declaration, what has happened? So I like to conclude it. Fundamental changes have occurred affecting health services delivery. Changes have further increased the critical importance of primary health care in its central role in sustainable development. It should aim to remain as the leader and a means to achieving health for all. My references are Park's textbook, Details, Oxford textbook of public health, our Dean Dr. Balwal's textbook of public health and community medicine, Adar's textbook, Suryakanta textbook of community medicine, and etc. Thank you. Yes.
जरी तुला कंटाळा 10 मिनिटाचा ब्रेक दिसेल देऊ शकतो बरं का आता भरपूर वेळ आहे
Okay, good morning all. I am Dr. Kharde Anup, Associate Professor, Department of Community Medicine. Today we are going to see the topic of national health priorities and the policies. So these are the objectives of the today's lecture. First, we are going to see health or the definition of health. After that, we are going to see the national health problems, how the prioritization has been made of these problems, what are the different challenges and concerns associated with these health problems, and we are also going to see some glimpse of the National Health Policy 2017. So I think it is prudent to know health before going to the National Health Policy. So what is health? You can say that the simple definition of health is just an absence of disease. But as per WHO definition, health is a state of complete physical, mental and the social well-being and not merely the absence of disease and infirmity. So health is more than that. It's just not an absence of disease and infirmity. That's why we should know the health before going to the national health problems and the priorities. So health has a different dimension. These are physical dimension, mental dimension, social dimension, vocational dimension, emotional dimension and the spiritual dimension. And to label any person as a healthy, there has to be well-being in all 6 dimensions. So let's see quickly what this dimension means. So physical dimension means every organ and the system working harmoniously with each other. And what is the mental health? Mental health means the ability to take a right decision at a right time. That is, the person is in a self-control. Next dimension is a social dimension. Socially healthy person is able to live harmoniously with each other. Next dimension is vocational. So, and vocational means occupation. So this dimension is related to occupation. As everyone knows, every occupation has a stress. So any person who handles occupational stress positively, he is a vocational healthy. Next dimension is emotional healthy. So emotional health means what? The ability to express emotion in a correct way. It is called as emotional health. And the last dimension is of spiritual health. Spiritual health is very difficult to define, but we can say that it is related to ethics, principle and integrity. So health is a multi-dimension and every dimension has different determinant. So to tackle these different health problems, we require a multi-sectoral approach. So this is the health. So what are the national health problems of India? There are n number of problems related to health in India. These problems could be direct or indirect. Let's see the list of national health problems. These are neonatal mortality, infant mortality, under 5 mortality, stillbirth, maternal mortality, anemia related health problems, then tuberculosis related health problems, then HIV AIDS, then malnutrition, then health problem which is due to the malaria, dengue, then health problems which are due to the waterborne diseases, then hypertension, diabetes, cancer, accidents, low gender ratio, then problems due to the sanitization and hygiene, then problem due to the menstruation and reproductive tract infection, then problems or health problems which are associated with urbanization. Then there are some health problems which are related to water pollution, air pollution, some problems which are related to addictions and mental health. Now currently we are also facing the epidemic problems like corona outbreak. Then we also have the problems related to natural disaster, low vaccination, low use of contraception, some problems related to home delivery. So like we have n number of problems. So that's why we have to prioritize this problem. So what is the logic behind prioritization of these health problems and how to prioritize these problems? So to prioritize these problems, we must have the health information related to morbidity and the mortality. So there are different sources from which we get this information related to morbidity and mortality. So it is nothing but the suffering of the people. And the sources which gives us the data, these are the census, registration of vital events, then some sample registration system, hospital records, disease morbidity register, then epidemiological surveillance, environmental health data, health manpower statistic, population health survey, etc. So all this survey gives us the information regarding the morbidity and the mortality patterns, and based on this health information, we prioritize the different health problems. So why it is important to prioritize this? As you must have known, there are different resources we require to tackle this problem. These are mainly man, money and the material. And we know that all the resources are always limited. So based on the available resources and available information or the data from the health management system, we have to prioritize which health problems get the first preference. So it is called as health prioritization. So like we have different health problems. With this problem also associated with different concerns and challenges. These are affordability. As you know, the cost of medical care is increasing rapidly. So there is an enormous out-of-pocket expenditure, which lead to we are pushing because of that more people in the poorer state. Next concern is related to quality and the standards of the medical care. Next, we also have the problems or the challenges regarding the shortage of skilled human resources, low public health spending. Next concern is related to the poor developed primary healthcare infrastructure, and whatever the infrastructure we have, it is underutilized. Next challenges is regarding the lack of political will and the poor utilization of available data. So all these health problems and the concerns and challenges which are associated and which result into the high morbidity and mortality. So let's see some highlights of the national health policy. So before the beginning, let me give the background of this national health policy. So after independence in 1982, Government of India launched the new 20 points program. Along with that, they have also announced the national health policy. So what is the reason of formulation of this national health policy? We have accepted the primary healthcare approach to the achievement of health for all by 2018, and which lead to the formulation of this national health policy. So in 1983, the Parliament of India accepted or approved of this national health policy. So main aim of this formulation of national health policy is to achieve the health for all through the route of primary healthcare approach. So we want to achieve the health for all through primary healthcare approach by restructuring the healthcare delivery system. So you should remember the concept of primary healthcare and the health for all. I will tell you in the next slide. So after 1983, the next policy came in 2002, and both these policy has served well in the guiding the approach of health sector in the 5 years plan. So apart from the national health policy, we also have the 5-year plan to achieve the health targets. So let's see what does mean by primary health care and the health for all. So in 1978, in ALMA-ATA International Conference, the new concept was introduced and it is called as primary health care. So you should remember the definition of the primary health care, and it is defined as the primary health care is an essential health care made universally accessible to the individual and acceptable to them, and through their full participation and at the cost of community and the country can afford. So through primary health care, we have tried to resolve what are the different challenges which are associated with healthcare delivery system. So these services should be essential, they should be accessible, they should be acceptable, and there should be a community participation, and it should be affordable to the people. So all these things are essential for the achievement of the health for all, and all the countries have accepted this approach to achieve the health for all by 2018. So after primary health care, let's see the definition of health for all. So ultimate aim of this national health policy in which we want to health for all, and health for all means the attainment of the level of health that will enable every individual to lead socially and economically productive life. So what the ultimate aim of health for all is, we want every individual should live economical and socially productive life. So this is the reason behind the formulation of the national health policy. So through the primary healthcare approach, we want to achieve the health for all, and for that we require to restructure whatever the existing healthcare delivery systems of India. So after the gap of almost 14 years, there is a lots of changes which has been take place in the Indian healthcare scenario, and this context has changed in 4 major ways. So what happened? First is there is a change in healthcare priorities. Initially, we had a burden of communicable diseases, but apart from that, now currently we have burden of communicable as well as non-communicable diseases. So we are facing the dual burden of diseases. Second thing which has been changed is emergence of the private sector as a robust healthcare delivery system. So private healthcare industry are playing the major role in the as a healthcare delivery system. The third change which we have seen is related to the cost of healthcare, and it has increased rapidly, and which are causing poverty because it causes the catastrophic out-pocket healthcare expenditure. And the fourth change we have seen the rising economic growth which enables enhanced fiscal capacity. So all these four changes to address all these four changes we have to require a new policy. So a new policy which is responsive to these contextual changes was required, and it was launched in 2017 with the primary aim is to inform, clarify, strengthen, prioritize the role of the government in the shaping the health system. So after a gap of 14 years in 2017 we had a new policy. It is called as National Health Policy of 2017. So this policy tried to address all the lacunae or the challenges we had before initially. So this policy based on the 10 principles. So these are the key policy principles. The first principle of National Health Policy 2017 is professionalism, integrity and ethics. And this has to be maintained in the entire system of healthcare delivery in the country. Second principle is equity, and equity is nothing but minimizing the disparity on the account of gender, poverty, caste, disability and other form of social exclusion and geographical barriers. So there should be equitable distribution of healthcare delivery system. Second principle on this policy is called as affordability. Like I said, the affordability means we want to reduce the catastrophic out-of-pocket health expenditure. So what does it mean? It means the health expenditure exceeding 10% of its total monthly consumption expenditure or 40% of its monthly non-food consumption expenditure. It is called as catastrophic household healthcare expenditure. And because of this out-of-pocket expenditure, many people are forcing to in a poor state. So next principle is of universality, and it is means the prevention of exclusion on social, economical on the grounds of current health status. The fifth principle of National Health Policy is called as patient. It is a patient center and the quality of care. So what does mean by patient centered healthcare? It is a healthcare which is gender sensitive, effective and safe and convenient healthcare services to be provided with the dignity and confidentiality. So it is called as patient centered healthcare. And also this healthcare should be quality, and this has to be maintained by different standards and guidelines for all the levels of facility and the system. Sixth principle of this National Health Policy, it is called as accountability, and it is the accountability of financial and the performance accountability. Next is transparency in the decision making and elimination of corruption in healthcare system in both public and the private sector. Seventh principle is based on inclusive partnership. As you know, health is a multi-dimensional and it's affected by multiple determinants. So to achieve a health for all, we require a partnership or the multi-sectoral partnership with all other non-health ministries and community, and it is called as inclusive partnership. So this approach would not include partnership with academic institute, but also from the non-profit agency and healthcare industry as well. Next principle is called as pluralism. Pluralism means what? Every patient should have choice or should have access to all the different modalities of treatment, whether it's an Ayurvedic treatment, allopathy treatment, Unani treatment, Siddha treatment or homeopathy treatment. So it is called as pluralism. Ninth principle of national health policy, it is called as decentralization. So whatever the different health programs or health services we are implementing at a community level, that particular community should have some access in the decision making, and this is called as decentralization. So the community participation in health planning process, it should be promoted, and this should be it is called as decentralization. And the last principle of national health policy, it is called as dynamism and adaptiveness. So it is a constantly improving a dynamic organization of healthcare based on the new knowledge and evidence. So there should be a constant improving based on the new knowledge or the evidence based medicine. So these were the 10 key principles we have seen of national health policy. So through this 10 key principles, we want to challenge to tackle the challenge or health priorities. So what are the health priorities? We also call it as specified goals and objectives. So first priority is we want to increase the life expectancy at birth from current 67.5 to 70 by year 2025. Apart from that, we also on a priority basis we want to reduce the under 5 mortality to 23 by 2025 and maternal mortality from the current levels to 100 by 2020. On priority basis, we also want to reduce the infant mortality rate by 28 by 2019. So other different health priorities are, we want to reduce the neonatal mortality to 16 and still birth rate to the single digit by 25. We also want to achieve the global target of HIV/AIDS, and that is we want to achieve the 90, 90 and 90. So what does it mean by? So what 90% of the people living with HIV should know their status. 90% of people who are diagnosed with HIV infection should receive a sustainable antiviral therapy, and the 90% who receive the treatment should have the viral suppression. So this is the health priorities regarding the reduction of the disease or the prevalence and the incidence. Next, we also want to, on a priority basis, we want to achieve the cure rate in more than 80% in the new sputum positive patient of the tuberculosis. Apart from that, we also want to reduce the prevalence of the blindness, and also we want to reduce the premature mortality which is associated with cardiovascular diseases, cancer, diabetes or any chronic respiratory diseases by 25% by year 2025. Apart from these health priorities, we also have the priorities regarding the health system performance. First is we want to increase the coverage of health services. So in short, we want to increase the utilization of the current health facilities by 50%. Also, we want to maintain or we want to sustain the antenatal coverage by 90%. And also there should be skill attendance at a birth in above 90% of cases. More than 90% of newborns should be fully immunized by the 1 year of age. Next health priorities is we want to meet the family planning above 90% at national or sub-national level by 25. Next objective is we want to achieve the 80% of known hypertensive and diabetic individual at household level to maintain a controlled disease status by 2025. Also, we want to reduce the reduction in the prevalence of current tobacco use by 50% by 2020 and by 30% by 2025. Next objective is we want to reduce 40% in the prevalence of stunting in under 5 children by 2025. And we also want to provide a safe water and sanitation to all through Swachh Bharat Abhiyan by year 2020. Next, on the priority basis, we want to reduce the occupational injury by half from the current levels of 334 per lakh agriculture worker by 2020. And we also want to develop a tracking system for the selected health behavior at both national and state level. So apart from the health system, we also want to, on priority basis, increase to health care expenditure from the current expenditure 1.15% to the 2.5% by 2025. Next is we want to ensure the quality care, and we want to also ensure the skilled healthcare staff should be available in all the primary healthcare center. So we have developed for that Indian Public Health Standard, and this should be implemented in high priority district area by 2020. Next, on priority basis, we want to ensure the district level electronic database of information on health system component by 2020. And we also want to strengthen the health surveillance system and also establish and federated integrated health information architecture, health information exchanges, and national health information network by 2025. So these were the health priorities we want to achieve by 2025. So in this policy, also identify the coordinated action plan on 7 priorities area for the improvement the environment for health. So these are Swachh Bharat Abhiyan, then balance healthy diets or regular exercise. Third is addressing the tobacco, alcohol and substance abuse. Fourth is Yatri Suraksha, that is preventing the deaths due to the rail traffic accident. Fifth is Nirbhaya Nari, that is action against gender violence. Sixth is we want to reduce the stress and improve the safety in the workplace, that is occupational related morbidity and mortality. And last is we want to reduce the indoor and outdoor air pollution. So these were the glimpse of the National Health Policy 2017. So we have initially seen that the health definition. So as per WHO definition, health is not just an absence of disease and infirmity, it's the well-being in all 6 dimensions of health. So we have to require a multi-sector approach to achieve the health for all through primary healthcare approach. So why we have adopted or accepted the primary healthcare approach? So based on the data, it is seen that the primary care remains the most cost-effective way. As per the US data, which shows that after implementation of this primary healthcare concept over a decade, there is a resulting in the 30% reduction in the hospital days, there is a 42% reduction in the emergency, and a 25% increase in the childhood immunization. And also the data from the Bhide shows that for every 1 lakh population, there was a reduction in the number of cardiovascular diseases cases from 40 to 27, and reduction in the hospitalization rate from 3.32 to 2.83. So the primary healthcare remained a cost-effective way. So it remains critically and effective in promoting the good health and reducing the disease in a cost-effective way. So that's why through National Health Policy, we want to achieve the health for all approach through the primary healthcare approach. So in the end, I want to show you different national health programs. So we have different national health programs. The components of the dimension of this national health program are 7. We want to achieve the RMCH plus A services. Another different national health programs are based on child health and adolescent health. We also have the national health programs on universal immunization. We also have the programs on communicable diseases. Then we also have the national health programs on mental health. Then we have national health programs on non-communicable diseases. And we also have the program on the population stabilization, that is family health program. So these are the different national health programs of the domain. So in the end, I want to show you that health is not just an absence of disease or the infirmity, and we require a multi-sectoral approach to the national health policy and different national health programs. Thank you. So in the next session, I am also going to show you the different topics which will be covered in the first year by the Department of Community Medicine.
There will be break for 15 minutes sometime.
We'll take a break for 15 minutes, then I'll continue with the next session.
आता तू दिसतोयस हे करू का मग तुझं बटन कुठं आहे Yeah. Good morning, students. Welcome back. Now I will be covering distribution of teaching hours and pattern of internal assessment in community medicine for your batch, that is 2020 batch. Our subject starts with first MBBS, is continued with second and third year, and even during internship, coordination of entire internship program is with my department. So let us first see timeline for your 2020 batch. Slide show now. इथे अजून दिसते. So January 2021 is your foundation course. Part of foundation course is being discussed online, and when we will come in the campus, the remaining part which require physical presence like skill modules and other modules will be covered subsequently when you join. So as per the NMC schedule, revised NMC schedule, your lectures and practicals will start from 1st of February, and the duration is of main course is 11 months, that is up to December 2021. Now this period will include 2 internal assessment examinations and 1 preliminary examination. And university examination for your batch will be conducted after 1 year, that is January 2022. It is January 2022, not 21. Now this is how the teaching hours will be distributed from February to December. For anatomy, there are 675 hours, including 220 hours of lectures, 415 hours of small group teaching, /practicals, and 40 hours of self-directed learning. For physiology department, 495 hours, including 160 lectures, 310 practicals, /small group teaching, and 25 SDL. For biochemistry, 250 hours, including 80 hours of lecture, 150 hours of small group teaching, and 20 hours SDL. Early clinical exposure, there are 90 hours meant for that. For my subject, community medicine, it is having 60 hours, 60 in first MBBS, out of which 8 hours will be covered in foundation course in the form of visits to health centers, visit to community health center, primary health center, sub-center, and Anganwadi. And remaining 52 hours will be covered when you join in February. There are 20 hours of lectures, 27 hours of practical or small group teaching or visits, and 5 hours of self-directed learning. Then there is Attitude, Ethics and Communication module, ATCOM module of 34 hours. Then sports and extracurricular activities 60 hours, and 80 hours are meant for formative and term examinations. So this is distribution for second MBBS, which I will not discuss. It's not immediately relevant to you. This is how we are distributing time in community medicine. Total 405 hours in phase 1, 2 and phase 3, including 2 clinical postings. So I told you 8 hours in foundation course, 52 hours in first MBBS, 60 hours in second MBBS, 72 hours as a first clinical posting in second year, 108 hours, 105 hours in third phase, and 108 hours for second clinical posting, which will be in third MBBS. Now please remember, this includes the pandemic management module hours. Out of 80 hours in pandemic management module, 34 hours will be covered by community medicine in clinical postings of second and third MBBS. In your first MBBS, you will face 2 examinations, internal assessment examinations, one theory of 50 marks and one practical again of 50 marks. Again in second year, you will have 2 examinations at the end of second first and second second. In third MBBS, again you will have 2 examinations, one at the end of third MBBS part, third first MBBS and one prelim. So this is how the table looks like, and ultimately those marks are to be converted out of 40, and you have to secure minimum 16 marks to be eligible to appear for the university examination. And for prelim as well as university examinations, you will have 2 theory papers in community medicine of 100 marks each, and this is the distribution of topics for paper 1 and paper 2. Each paper will have multiple choice questions, MCQs for 20 marks, and short answer and long answer questions of remaining 80 marks. So this finishes my topic of time distribution in community medicine and internal assessment pattern in community medicine. Now I invite Dr. Anup Kharde again. He will be taking your lectures when you join first MBBS. So over to Dr. Anup. Anup.
Welcome back. I am Dr. Kharde Anup, Associate Professor in the Department of Community Medicine. So before telling the topics of the theory lectures, let me quickly revise what we covered in the morning. So Department of Community Medicine, in the today morning we have covered 2 important topics. First is primary health care, and second is national health problems and its priorities. So what you should remember, the 4 key principles in the primary health care, and these are community participation, second is intersectoral coordination, then appropriate technology and equitable distribution. And you should remember what is the meaning of all these 4 key principles. So in next session, that is national health problems and the priorities, we have covered what definition of health, because it is what are the different national health problems and how to prioritize, or what is the logic behind the prioritization of the health problems. Next we have seen what are the different challenges and the concerns which are associated with national health problems. Also we have seen some glimpse of the national health policy. In this session, we have also seen the background of national health policy. That is, we had National Health Policy of 1983, National Health Policy of 2002, and currently we have National Health Policy of 2017. After that, we also seen the concept of primary health care and health for all. So this is the reason for the formulation of the National Health Policy. In the next objective was the key principle, and what the key principle, there are total 10 key principles of the National Health Policy we have seen in the details. And in the last, we have also seen the goals and objectives or the health priorities of National Health Policy. So these were the two topics we covered in the morning. So in this session I am going to tell you the topics which will be covered in a theory lectures. So your theory lecture, there will be two main heading. One heading is regarding the nutrition and second is regarding the community health and disease. So in the nutrition there will be 10 lecture, and in community concept of health and disease there will be 10 lectures. So there will be a total 20 lectures in the theory class. So in the nutrition we are going to cover common food groups and the nutritional significance. Next is nutritional requirement of different members of the community. In the next lecture we are going to cover nutritional assessment at individual, family and the community level. Then we are also going to cover nutritional deficiency, disorder, epidemiology and its control and the prevention. We are going to see what the nutritional surveillance means and nutritional rehabilitation. Then next lecture is on National Nutrition Policy. After that there will be a lecture on National Nutrition Programs. Next lecture will be on food hygiene and adulteration, and second last lecture will be on food fortification and additives, and the last lecture will be on food processing, food preservation and food toxicity. So this will be a 10 lecture which will cover all the topics which are relevant to the nutrition. In the next session there will be lectures on concept of health and disease. So this will be also a totally 10 lectures, and we will be covering on the community diagnosis, then concept of public health, then what are the determinants of health, then what does mean by epidemiological triad, then what are the different causation of the diseases. There are different theories like multifactorial causation, the epidemiological triad, etc. Then also in this session we are going to cover national history of disease. Then there are levels of prevention, there are different levels of prevention. Then indicators of health. We are also going to see the important concept of health education, that is how to develop IAC and VCC, that is information education communication for the behavioral change communication. And in the last session in the last lecture we are going to see how to evaluate the national health education program. So these will be a totally 20 lectures covering the importance of nutrition and the concept of health and disease. Also we are after this theory lecture there will be a lecture practical session in which we are going to cover the family studies. You will be allotting the 5 family studies in the community, 5 families in the community, and you are supposed to follow up them and collect the data which is relevant to the morbidity and mortality. And also along with that there will be some practicals on the nutrition assessment. So this is it. This will be cover your both theory lectures on the nutrition and the concept of disease, and the practical component on the family studies, and some exercises which are based on the nutritional assessment. Okay, thank you.
Hello students. Now I declare that today's sessions are over. All the PowerPoint presentations of today's session will be uploaded on Google Classroom, and we request you to go through them in the afternoon, and you can take few notes in your notebook which will be helpful for you for writing logbook. So thank you everyone for your patient listening. Have a nice day. चल चल भेटू उद्या
ओके सर.
उद्याची लिंक करताय उद्या टॉपिक हे बघा 14चे